for coming, and thanks for inviting me to this meeting. It's been fantastic so far. I'm glad that Rachel and Jan spread some light on all these complicated things. I'll try to add some science into this as well. So in case you fall asleep during my presentation, these are actually the take-home points. So I would argue that the treatment of uncomplicated dissection with regards to TEVAR is largely unknown. There seems to be a reduced risk of aortic-related events during midterm follow-up. There are some anatomical risk factors that both Jan and Rachel mentioned that will go into depth that might exist and might be predictive, but very few of them actually stand out. If we do TEVAR in uncomplicated dissections, we should hold off a little bit just to wait to see if the patient stabilizes. But we also have to remember that a simple, straightforward TEVAR, perhaps as the cases that Jan showed, is not always possible due to anatomical limitations. So in conclusion, we do need better trials. You've already seen this, and this is the reporting standards from the SVS, came out 2 years ago, and actually defines the chronicity of dissections, and it's good. We have now hyperacute going on to chronic, and also the delineation of complicated versus uncomplicated. So when it comes to complicated dissections, as Jan pointed out, I think that there's no question TEVAR is our first choice and that it is truly indicated. We know why we do it, to cover the entry tear, the rupture site, and to promote true lumen flow and thrombosis in the false lumen. And we do know that the numbers, although the numbers aren't great, they're still much better than the numbers that are available for open repair in this setting. But remember, this is still a very morbid procedure for these patients, but the option of not treating them, of course, is even worse. So what about these uncomplicated dissections? And for a moment, just think away all these high-risk factors and focus on the patients that have no rupture, that have no clinical malperfusion, and then have no high-risk features. Well, I would argue that the debate is still ongoing. This is from the current issue of the British Journal of Surgery, and you can see here we have two camps. One that goes, put TEVAR in everybody, and one that says, hold off, just give them the best drugs you have. What we agree upon is, of course, the timing, and that goes back to this study that's already been quoted, because we seem to have severe complications if we treat patients with TEVAR in the hyperacute and acute phase as compared to the subacute phase. So delayed intervention is probably warranted. If we look then at uncomplicated outcomes, of course, everything started with this INSTEAD trial that now dates back, the publication dates back 13 years. Patients were included up to 52 weeks after symptom presentation, important to remember, and it was powered to show differences at 2 years, which it actually did not. So there was no difference in aortic-related or overall outcomes at 2 years between TEVAR and optimal medical therapy in this trial. The European guidelines are very cautious when it comes to this. In fact, they don't even quote the INSTEAD trial, only Professor 𝗔𝗀𝗋𝗋's adsorb trial, and state that you may put a TEVAR in somebody, you have to consider it very selectively, and you can see the level evidence 2B with a grade B classification. So not a lot of data to work with. But in the meantime, other trials come out, as this one. Most of them are retrospective, and this one very recent from the US, from Will Jordan's group, showing that if you treat a complicated dissection with a TEVAR, it actually does better than if you don't treat an uncomplicated dissection with a TEVAR. So they then claim that you should put a TEVAR in everybody who comes along the street. And then, of course, the INSTEAD XL trial with this landmark analysis where they pulled the patients out to 5 years and saw that, yes, if you use TEVAR 2 years after onset, I guess, then it's better than optimal medical therapy and reduces the aortic-related events. Highly debated, but still probably the best evidence we have on this. So back to the reporting standards. Can we and should we use the high-risk features to identify patients that perhaps are better suited for this? This stems back from the IRAD data, Santi's group, who showed that there were a number of risk factors that seemed to predict progression of aortic disease. Bless you, Germano. And these were parts of it, and you see them here. So this has been well studied. Again, another trial looking at exactly this. They took all their patients and looked at all these complicating factors and said that, well, if patients were stratified into these two cohorts, there's those with risk factors anatomically and those without anatomical risk factors, the patients who eventually underwent intervention did much better than those who eventually did not. So in fact, what they're saying is that dissections with these characteristics should be treated because our study showed that we treated those patients with these characteristics. It's sort of inverse reasoning that really doesn't work. So if we look in a systematic review at all these risk factors, and you can see them here again, aortic diameter, rapid expansion, 40 millimeters, and so on, going through the list, most will find that the only significant complicating risk factor is indeed an initial aortic size of over 40 millimeters. And if you treat these with only best medical therapy, they have a higher risk of developing major adverse events. And this makes them potential candidates for TEVAR. So you can do sort of cheapskate randomized trial. This is a propensity score matched cohort of 190 versus 166 patients, TEVAR versus best medical therapy. And the authors then conclude that yes, if you include uncomplicated patients with rapid expansion to over 40 millimeters in the initial setting, there seems to be a better outcome if you treat these patients with TEVAR. But systematic reviews showed that this is not pertinent to mortality, only to aortic-related outcomes, and this is the evidence that we have. And the results of these systematic review are not conclusive. It would seem that large, well-designed, randomized trials are examining late outcomes are still needed. So, this is the Sunday trial. It's going to start January 1st and includes 20 centers in the Nordics, catchment area of 30 million people that are going to be randomized between standard medical therapy and standard medical therapy and TEVAR after 2 weeks. These are the sites and the exclusion criteria, not so many, as you can see here. And we're going to randomize 550 patients over a period of 2 years. So in summary, for those of you who just woke up, the best treatment of uncomplicated type B aortic dissection is still largely unknown. Randomized controlled trials suggest that TEVAR reduces aortic-related death and events, but not all-cause mortality. With regards to risk factors, an initial aortic diameter of more than 40 millimeter seems to be the most relevant. If TEVAR is indicated, try to hold off 2 weeks. But remember that simple TEVAR is not always possible in all patients due to anatomical limitations. We need and we will have better trials. Thank you.